Myocardial infarction, commonly known as a heart attack, is a life-threatening condition that occurs when blood flow to a part of the heart is blocked, causing damage to the heart muscle. Symptoms typically include chest pain or discomfort, which may radiate to the arms, back, neck, jaw, or stomach, shortness of breath, and sometimes nausea, cold sweats, or lightheadedness. On the other hand, a stroke happens when the blood supply to the brain is interrupted or reduced, preventing brain tissue from getting oxygen and nutrients, leading to symptoms such as sudden numbness or weakness in the face, arm, or leg, especially on one side of the body, confusion, trouble speaking or understanding speech, and difficulty seeing in one or both eyes. Treatment for both conditions involves rapid emergency care, with heart attacks often treated with medications, surgery, or other procedures to restore blood flow, while stroke interventions may include clot-busting drugs, mechanical clot removal, or surgery to reduce the risk of further strokes. Risk factors for both diseases include high blood pressure, high cholesterol, obesity, diabetes, and smoking, as well as a family history of heart disease or stroke. Here's a detailed look into both these critical cardiac and cerebral events, highlighting their distinct and overlapping aspects. Affected vascular territory, coronary versus cerebral. Myocardial infarction, MI, and stroke are both vascular events but affect different territories. MI involves the coronary arteries supplying the heart, while stroke targets the cerebral arteries nourishing the brain. MI typically presents with chest pain or discomfort, potentially radiating to the arm, neck, or jaw, and may be accompanied by sweating, nausea, and shortness of breath. Contrastingly, strokes manifest with neurological deficits like facial drooping, limb weakness, speech difficulties, or sudden onset of confusion. Identifying the affected vascular territory is critical for intervention. MI is often treated with revascularization procedures such as angioplasty, while stroke may require thrombolysis or thrombectomy, depending on whether it's ischemic or hemorrhagic. Time is tissue in both scenarios. The faster the blood flow is restored, the better the outcome. Predominant symptoms: chest pain versus neurological deficits. Myocardial infarction, MI, typically heralds its onset with intense, prolonged chest pain that can radiate to the arm, neck, jaw, or back, often accompanied by sweating, nausea, and breathlessness. In contrast, a stroke manifests with a sudden loss of brain function, which can include paralysis of one side of the body, difficulty speaking, dizziness, or altered vision. The crucial diagnostic focus rests on identifying these symptoms quickly, as both conditions are time-critical. Timely intervention can significantly improve outcomes, with MI treatment focused on restoring blood flow to the heart, while stroke management aims to protect the brain either by dissolving or removing clots or managing a bleed. Risk factors: prevalence, atherosclerosis versus atrial fibrillation. Both myocardial infarction and stroke are cardiovascular events often resulting from atherosclerosis, but their risk factors can diverge significantly. Atherosclerosis, characterized by the buildup of plaques in arterial walls, is a major risk factor for MI. It contributes to coronary artery disease, which can obstruct blood flow to the heart muscle, leading to an infarction. On the other hand, atrial fibrillation, AFib, a common arrhythmia, increases the risk of stroke. AFib can cause blood to pool in the heart's chambers, forming clots that may travel to the brain, causing ischemic stroke. While both conditions share common risk factors such as hypertension, smoking, and diabetes, the prevalence of atherosclerosis tends to be a stronger predictor for MI, whereas AFib is more specifically associated with an increased risk of stroke. Understanding these risk factor prevalences is critical for both prevention and the differential diagnosis of these life-threatening events. Acute management, revascularization versus thrombolysis, neuroprotection. In acute management, myocardial infarction and stroke represent a critical time window where treatment choices significantly impact patient outcomes. For MI, revascularization is the gold standard, often through percutaneous coronary intervention, PCI, to restore blood flow to the heart muscle swiftly. In contrast, acute ischemic stroke management frequently involves thrombolysis, administering clot-busting drugs like TPA within the first 4.5 hours. However, selected cases may benefit from mechanical thrombectomy, akin to revascularization in MI. Meanwhile, in hemorrhagic strokes, the focus shifts towards controlling bleeding and reducing intracranial pressure, unlike MI, where blood flow restoration remains the cornerstone. Both conditions urgently require precise diagnostics to tailor the intervention, critical in improving survival and functional recovery. Potential complications: heart failure versus cognitive impairment. When comparing potential complications of myocardial infarction, MI, and stroke, the impact on different body systems is evident. Post-MI, a common complication is heart failure due to the heart's decreased ability to pump blood effectively, leading to fatigue, shortness of breath, and edema. Conversely, stroke survivors often face cognitive impairment as a result of brain damage. This can manifest as memory loss, difficulty in processing information, and problems with attention and problem solving. The severity of these complications often relates to the extent of the organ damage, with both conditions potentially leading to chronic health problems and a diminished quality of life.